Okay, so we'll start the webinar tonight with the acknowledgement of country. In the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past, present and extend our respect to all Aboriginal and Torres Strait Islander peoples today. So the webinar tonight will feature two speakers, and we're very fortunate to have Bonnie Yang as the first speaker tonight, who is from Sydney Urological Associates. Bonnie is an experienced nurse practitioner with a specialised focus in functional urology and pelvic health, with over a decade of nursing experience and graduate qualifications, including a Masters of Nurse Practitioner and a graduate certificate in stomal therapy. Bonnie brings a comprehensive skill set to her advanced practice role. Bonnie currently practices with Sydney Urological Associates, where she collaborates closely with urologist Dr. Amanda Chung in both diagnostic and interventional procedures. She remains committed to integrating evidence-based practice and advanced clinical skills to optimise patient outcomes in urological care. Questions will be at the end of Bonnie's presentation. Welcome, Bonnie.
Thanks, Melissa. I'm just going to share my screen here. Let's do that. There we are. There we go. Can everybody see the screen okay?
Yeah.
Okay, perfect. Let me just get to this part. Wonderful. That's looking all good?
Yes, thank you.
Okay, perfect. So hi again, everybody. My name is Bonnie. I am a nurse practitioner specialized in functional urology. And today I'll be talking about urinary incontinence. There we go. Okay, so as we all know, incontinence is one of the common conditions that affects the quality of life of many. And it also posed a huge burden in the economy. So urinary incontinence is defined as the involuntary leakage of urine, which can be a result of problems with the bladder storage, urethral closure, bladder emptying, and certain neurological condition, as well as functional ability. Just go down. Okay. So first, I would like to talk about how does continence maintain. So in order to maintain continence, we rely the bladder to store urine at a really low pressure. And we also rely on the bladder to be able to sense the amount of volume that's building up and be able to feed that back to the brain and tell the brain that the bladder is at certain capacity and when does it need to evacuate and when it's not full yet. And then we also rely on the external urethral sphincter to remain closed during filling to contain the urine, as well as the pelvic floor muscle to support the urethral closure. So the way that I would like to explain to my patient is when we're thinking about bladder storage function, imagine your bladder is like a balloon. So as the bladder is getting filled up by urine, it's supposed to keep stretching just like a balloon while maintaining a low pressure. And during voiding, what happens is the muscle layer within the bladder, that's the detrusor muscle, supposed to contract. And then the sphincter, urethral sphincter, is supposed to relax, and that allows the urine to flow out. So for normal urinary incontinence, that requires the coordination between the bladder, the pelvic floor, as well as the brain. Okay, so there are different types of urinary incontinence, as we all know. So the couple of incontinence that are listed are stress urinary incontinence, urge urinary incontinence, and some people, they can have a bit of both. So that's mixed urinary incontinence, overflow incontinence, as well as functional incontinence. So for stress urinary incontinence, we are referring to the urine leakage that's associated with the sudden increase in intra-abdominal pressure. So if we look at the diagram on the right-hand side here, we can see the bladder here. So when the bladder is full, when there is external pressure, so that's the intra-abdominal pressure coming down onto the bladder, that causes the increase in intravesical pressure as well. And that forces, when that pressure exceeded the closure pressure of the sphincter, then it leads to urine leakage. So that's stress urinary incontinence. For urge urinary incontinence, it is referring to the complaint of involuntary loss of urine associated with urinary urgency. So when that happens, the bladder is full, or is the bladder sense that it's full, and the bladder muscle starts to spasm, and that spasms causes again the intravesical pressures to go up, and when that pressure goes over the limits of the sphincter closure pressure, then it forces urine out. So that's urge urinary incontinence associated with a detrusor overactivity. And some people can have a bit of both, can have mixed urinary incontinence. Quite often we see that in male patient post-prostatectomy, particularly if for those who had previous radiotherapy history. And then we have overflowing incontinence. So imagine if a bladder is full, quite often that's due to prolonged history of chronic obstructions or any other underlying pathology. When the bladder is built up with a high amount of urine, eventually it reaches its capacity and won't be able to accommodate more, then it leaks out. And lastly, we have functional incontinence. So that refers to the person's inability to reach to the toilet in time, despite that there is actually accurate urinary tract function. So usually that is due to either cognitive issues or mobility difficulties. Okay. Sorry, just go back to one before. Okay. So for stress urinary incontinence, like I described previously, so that is referring to the leakage that occurred when intra-abdominal pressure increases. So like this little diagram here, and the common triggers of this type of incontinence is coughing, sneezing, laughing, exercise, or a lot of heavy lifting. So the urethral closure pressure is usually insufficient. Well, in this type of incontinence, the urethral closure pressure is insufficient to prevent that leakage, to counteract that intra-abdominal pressure. So with SUI, it is often associated with the pelvic floor weakness, urethral hypermobility, as well as the intrinsic sphincter deficiency. And some of the risk factors is listed on the right here, such as pregnancy, pelvic floor weakness, pelvic floor surgery in the past, prostate surgery in the past, obesity, hormonal changes such as menopause, chronic cough, and high impact activities, as well as heavy lifting. For urge urinary incontinence, that is, again, referred to the sudden compelling desire to urinate, followed by the involuntary leakage that occurs before the person is able to reach to the bathroom. And it is usually associated with other symptoms such as urinary frequency, nocturia, and the urgency to urinate. This usually occurred in the context of an overactive bladder. And with the underlying problems associated with urge urinary incontinence, it usually is associated with the inappropriate bladder contractions during that storage phase. Or some people can also have overactive bladder with just abnormal bladder sensation. So that is to do with the interruptions in the afferent signaling. I think, yes, okay. good that I put these slides here. So when we talk about urge urinary incontinence, we think about an overactive bladder. However, overactive bladder itself, there's actually quite a couple of different subtypes. And overactive bladder is actually a symptom syndrome. So it is diagnosed. It is diagnosed by the presentation of the symptoms. All right. So it is defined. It is defined as, just a typo on my slides there. The urinary urgency in the absence of a proven urinary tract infections or other obvious pathologies. And this is often accompanied by a urinary frequency and nocturia. And an overactive bladder can associate with urge urinary incontinence or without urinary incontinence. So that's the important part to distinguish. With an overactive bladder, the diagnosis is based on its symptoms, like I mentioned before. But in diffuse overactivity, the involuntary spasms of the bladder is actually a urodynamic finding. So I just got this graph here. I'm hoping that will help to explain an overactive bladder a bit better. So in normal bladder functions, for instance, when the bladder is getting filled up, the stretchy receptors on the bladder wall will send through efferent signals through the different nerves. Oh, where's my mouse? Yep, sorry. Through different nerves to the spinal cord and into the brain. And the brain will be able to interpret the signal to be able to distinguish whether or not now the bladder is full and if the person need to make his way to the bathroom to urinate. So the mechanisms is actually rely on a couple of the reflexes, the guarding reflex. So with the guarding reflex, it is important for us to understand how the sympathetic nerve system, the sympathetic nerve pathway, and also the parasympathetic nerve pathway works. So to maintain continence, when the bladder is getting filled up, the sympathetic nerve system is activated. So that means the hypogastric nerves is activated, and then that relaxes the bladder and closes, and it also increases the pressure of the bladder neck to allow the bladder to hold on and accommodate more urine. Meanwhile, the pudendal nerve also stimulates the pelvic floor, and that also further helps with the contractions of the pelvic floor, the external sphincter, and to achieve continence. All right, and then when the person needs to go to the toilet, when the brain is sends enough of the efferent signal, and then the brain will send through efferent signals, so that's the motor signals, down to the pelvic nerve, and that will cause the bladder to contract. And will also inhibit the actions of the hypogastric nerves and also the pudendal nerve, thereby reduces the activity. So allow the bladder to contract and allow the sphincter to open to relax, so urine flows out. So what we know about overactive bladder is there is a distortion or disruption in those guarding reflexes that I just mentioned. So there is, when the bladder is getting filled up, there's actually a lot of the efferent signaling being firing up through the nerves, and it's being feedback into the spinal cord and to the brain. And then when that signaling surpasses the brain's ability to inhibit voiding, then it actually causes a premature initiation of the efferent pathway. So by triggering the pelvic through the pelvic nerve and triggering the bladder to contract before it's supposed to. I hope that makes sense. So that is an overactive bladder. Sorry, I'm just lost my slides there. Okay, so when a person has an urge urinary incontinence, quite often when we do a urine dynamic study, we do see the finding of a diffuser overactivity. But the important distinguish in here is an overactive bladder does not always mean there is incontinence involved. Sometimes the person can present with just increase in urinary urgency, but without incontinence. Okay, so the next incontinence I'm going to talk about is overflow incontinence. So that happens when the bladder is not able to empty properly. So there's high amount of urine is remained in the bladder after voiding. This could be a result of chronic bladder obstruction, which causes the long-term bladder overdistension. And it can lead to diffuser underactivity. And eventually, urine will leak when the bladder capacity or pressure is exceeded. And again, that's associated with high post-void residual. And some of the presenting symptoms could be weak urine stream, urinary hesitancy, abdominal straining to void, the feeling of incomplete bladder emptying, post-void dribbling, and also frequent small volume voids. And for overflow incontinence, there's two things to consider when we investigating into our investigations. So the first thing is there any underlying problem suggesting of bladder outlet obstructions? So that could be enlarged prostate, could be urethral stricture, could be pelvic organ prolapse, or other obstructive pathology. Or is the bladder itself functioning normally? So if there is actually diffuser underactivity, which could be caused by neurological disease, diabetes, neuropathy, and chronic overdistension of the bladder, certain type of medications, and it can also be age-related changes as well. And then we have the mixed urinary incontinence, which is, again, the presentation of both stress and urge urinary incontinence and functional incontinence. That is referring to the person unable to reach to the toilet in time. And the person may be unable to reach to the toilet or remove their clothing in time, or sometimes they may even be able to recognize the need to urinate, or they're not able to use the toilet independently. Okay, so when we see a patient coming in with urinary incontinence, there are generally quite a few things that I will look at through my history taking. So first of all, I would like to think about is when did they leak? So is there any particular trigger that caused a leakage? If there's any certain patterns, and if there's any urgency associated with the leakage, how frequent do they normally go to the toilet? And how often do they get up to go to the toilet? If there's any urine leakage at nighttime, and if they are using any continence aids such as pads, how many do they go through a day and night? And what is the normal voiding volume? Are they just doing a small void, or are they able to release a good amount of urine? And then I would also like to think about, and I would also like to ask the patient about their voiding symptoms. If there's any abnormal voiding patterns, such as hesitancy, intermittency, weak streams, or do they feel empty after they urinate? And yes, I will also talk about whether or not there's any history of bloods in the urine, so hematuria, or any history with recurrent urinary tract infection. And then what about the bowel habits? Do they get constipation often? Do they have any neurological conditions or any previous surgery involved in the pelvic floor organs. Involved in the pelvic floor and pelvic floor organs, as well as whether or not they have any previous treatments to the prostate, and then their lifestyle factors. So what kind of fluids do they normally consume? And in the diet, do they normally consume a lot of those food or fluids that will irritate their bladder? And what is the drinking habits? Do they normally hydrate enough with good amount of water per day, etc.? Okay. So a part of my assessment, I will require my patients to complete a 2 to 3 days bladder diary. And that with a bladder diary, that records the time of each void. And I will encourage the patients to be measuring the voiding volume, and also record down the oral fluids intake, including the type of fluids and the amount of fluids, and urgency episodes. So usually I get them to rate it in a scale of 1 to 10. 1 is in very comfortable, 10 is in running to the bathroom, very desperate. And then I would like for them to record down the leakage episodes or pad changes. And if there is any nocturia, they can also record it in the bladder diary as well. And this helps us to identify any issue with urinary frequency, any severe urgency. And it will also give me an idea of how much the bladder is happy to hold. And then when we look at the oral fluid intake, I will be able to look at the type of fluid that they have and the amount of fluid that they have, and what is the time when they drink certain fluids. If someone is having quite a lot of urgency, urgency and frequency at nighttime, so when do they normally stop drinking fluids in the evening? And it also helps us to calculate for certain conditions, such as nocturnal polyuria. And it will also give me an idea of the patterns of the leakage. If it's associated with when they exercise or in the common session, they can also record that down. Or if it's mostly associated with urge, or if the leakage episode is associated with when they're at the gym or going for a jog, etc. Okay. And for patients that comes in to see me for a continence assessment, I will also perform a physical examinations as well when appropriate, with patient's consent, of course. And the type of physical examination, it depends on the presentation itself. But quite often it will involve an abdominal examination, assessment of the pelvic floor organs, so to check if there's any pelvic organ prolapse, and if there's any lower leg edemas, also to assess the mobility and the cognition level. And if appropriate, I will also do a digital examinations to the prostate with consent. There we go. And a couple of investigations that I usually consider is MSU for culture, if there's any suspicions of urinary tract infection, post-void residual bladder scan, uroflowmetry, bladder diary, like I mentioned previously, a renal tract ultrasound or other upper tract imaging, if it's appropriate. With patient that's got a bit more complex presentation, then we will also consider a urodynamic study, but this will be further down the track on usually it won't be at the first review. And not every patient with urinary incontinence require a urodynamic study. With the urodynamic study, it does give us a good picture in terms of how the bladder function, and allows us to understand how is the bladder symptoms and the bladder, how is their bladder habit in their day-to-day life per se. However, it is a invasive procedure. It involves a catheter being inserted into the bladder and also a sensor being inserted in the rectum. And for some patients, that might cause be more of a discomfort and some mental stress as well. So we do consider urodynamic for complex cases only usually. And urine cytology, if there is any indications of any bloods in the urine or any microhematuria that's picked up in the MSU. And cystoscopy, if it's clinically indicated, and that will be performed by the urologist. Okay, so in terms of management, there are the first line of management of urinary incontinence is conservative management. So the conservative management is aimed to address any reversible causes. So we want to look at the patient's lifestyle, look at their fluid intake, what type of fluids that they drink, are they drinking enough water during the day, and if there is constipation at the background, we also would like to address that or try and address that as much as we can. And weight management is also recommended. And along with smoking cessations, bladder retraining, pelvic floor muscle training, and also addressing any mobility or toileting problems. And of course, for conservative management, we also would talk to the patient about continence aids, and depending on the levels of the leakage, which will allow us to suggest different types of continence aids. Oh, sorry. There we go. And pelvic floor muscle training. For pelvic floor muscle training is also one of the conservative management strategies that I employed, and I encourage patients to do. So for stress urinary incontinence, by performing the pelvic floor exercise, it helps to strengthen the pelvic floor, and it also improves the urethral closure during a sudden increase in the abdominal pressure. And for urge urinary incontinence, urinary urgency, and as well as urinary urgency, by contracting the pelvic floor, it actually helps to suppress that urge to urinate. This is done, so the mechanisms behind that, I should say, is when the pelvic floor contracts, it actually triggers the afferent signal firing through the, actually, I think if I go back to this slide, it might make it a bit easier to explain. Okay, so we come back to here. So when we activate the pelvic floor, and that triggers the external sphincter and triggers the afferent signaling to be firing from the sphincter and travel up to the pendental nerve, and that itself would also encourage the hypogastric nerve's activation, which relaxes the bladder, therefore reduces the urge to urinate. Sorry, now I have to get back to the other page, sorry. No. I think I've gone a little bit too far. There we go. Yeah. Okay. But it is quite important to make sure that the patient is actually performing the pelvic floor exercise correctly, because with incorrect technique, that can actually cause a lot of pelvic floor issues. Therefore, I often will refer persons to see a pelvic floor physio, just so that they can be taught how to perform the pelvic floor exercise correctly, and the physio will also be able to monitor the progress. Oh, yeah. Okay. Yeah. So for treatments of an overactive bladder or urinary incontinence, so of course, in combination with the conservative management strategies, making sure they're staying away from any bladder irritants, hydrate, and fluid management, etc. So with the overactive bladder, there is medication that could help. So a couple of the common options that we see on the market is the anticholinergic, so the sulfenacin, which is by the name of Resicare, or oxybutynin, ditropin. And then we have the beta-3 agonist as well, which is mirabegron. So that's the Bemega. And then if the overactive bladder is refractory to conservative treatment as well as the pharmacological treatments, then we have advanced treatment options. So one of the common treatments to treat an overactive bladder or decrease overactivity is Botox injections. So the surgeon will inject a small amount of Botox into the bladder wall. By doing so, it paralyzes the detrusor muscle, which helps to combat that involuntary bladder spasms, and allow the persons to hold on to urine for a longer period of time, allows the bladder to hold on to more urine, and causes less urgency. However, sometimes when there is cases when the bladder works too well per se, then it can also lead to the side effects of urinary retention. Therefore, patient selections for this type of treatment is quite important. And ideally, we would like to pick the patients that will be willing and also is capable to perform self-catheterization if high residual do occur. And then we have nerve stimulation therapy. So with the less invasive options, we have the PTNS, which is percutaneous tibial nerve stimulation. That is this machine here. So a small acupuncture needle will be inserted just at the back of the ankle, and then that will be attached to this lead with a little electrode patch stick on the person's foot and connected to this impulse generator. So the impulse generator will send electrical signals through the lead and the needle down to the tibial nerve, and then to stimulate that nerve. And by doing so, it allows the bladder to relax a bit more to allow the bladder to hold on to urine a bit more calmly. And similar concept is the transcutaneous tibial nerve stimulation. So the difference between the two is one PDNS does involve the acupuncture needle, and the TTNS is just two electrodes. So there's no needle, no punctures involved. And then for the more invasive, more advanced nerve stimulation, we have the sacral neuromodulation, such as the implants that you're seeing at the bottom of this page here. So the implants involve a lead. This is the lead here, and attached to a impulse permanent implants. That's the impulse generator. And this lead will be inserted at the lower part of the sacrum. So it's aimed to be inserted really close to the S3 nerve, the sacral nerve, and stimulate the S3 nerves. By doing so, it helps to remodulate that communication between the bladder and brain, just like I explained before about the overactive bladder. Okay. And then, of course, lastly, if all therapy fails, unfortunately, then an indwelling catheter is also an option, just to help to divert the urine to to rest the bladder, basically. And then we have treatments for stress urinary incontinence. For conservative management, again, we have pelvic floor muscle training, weight management, and also lifestyle modification, such as making sure the person goes to the toilet in a timely manner, or if they tend to leak before any heavy exercise, any gym sessions, making sure they empty their bladder before performing those activities. And for women, we, if it's appropriate, we also recommend, we can recommend the continent pessary. However, with the pessary, with the patients that are suitable for pessary, we also need to make sure that they are able to manage the pessary themselves, or they are able to come back for follow-up. And then if that's not an option for those women, then we can also talk about any other surgical options as well, such as mid-urethral sling and etc. And then for men, there is pelvic floor rehabilitation, male sling, and as well as artificial urinary sphincter. And mind you, artificial urinary sphincter is also suitable for women as well. So these are just some of the photos for the different surgeries. So this is a male sling, it's an Adam sling. I don't know whether you can see it well in this picture, but there's basically a fluid-filled capsule here. It acts like a little cushion. So the surgeon will put the sling in, and then they will inflate this little cushion with normal saline, and by doing so, it increases the closure pressure of the urethra. And that's a vent sling, and then that's the artificial urinary sphincter. So, which is a 3-part system. You have a reservoir which holds the fluid to control the cuff, open and closes. That's the cuff. Which is put around the urethra, and then this is the button. So when the or the pump, when the person needs to urinate, they hold on to the end part of the pump, and by compressing it, that changes the fluid settings in the 3 parts here, and which drains the fluids out of the cuff side and opens up the cuff and allows urine to drain. And the device itself the cuff itself will close down in about a minute or a minute and a half by itself. And all that is due to the pressure regulations in the reservoir. Okay, so for treatment for overflow incontinence, the priority here is to restore a safe bladder emptying. It's quite important to treat the overflow, treat the retention rather than just treating the symptoms of the urinary incontinence. So we want to look at the underlying causes of the retention. Is it because of an obstruction, or is it because of certain medication? And we also want to consider the urodynamic study to assess if there's the detrusor function. And for certain patients, we will monitor their PVR and also consider teaching them how to self-catheterize if appropriate. And if not appropriate, then considering a indwelling catheter or permanent catheter. Some of the red flags when we need to consider or be aware of when we doing our assessment is if there is any concern, of course, we need to know when to escalate. Some of the scenario we includes if there's any significant changes in the post-war residual or in the overall presentation symptoms, if there is any hematuria, any recurrent UTIs or more UTIs in a short period of time, if there's any flank pain, any neurological symptoms, any suspected neurogenic bladder, or any unexplained leakage. And then the obvious, if there's any pain to the bladder as well as the pelvic floor, or any rapid deteriorations in the patient's condition. And to help patients with managing the incontinence, there is different support through the government. So one is the Continent Aid payment schemes. So I'm sure a lot of you are very familiar with these schemes and probably help many people applying for it. And with the Continent Aid payment schemes, there's certain criteria that the person must meet in order to receive the funding for it. And I believe this year is coming up to $600 something, close to $700 a year for to help the patients to purchase the continent equipment. And then in New South Wales, there's also the Enable New South Wales, which is suitable for people that's already been on CAPS but needed some more helps acquiring the products, such as catheters, pads, and etc. So this is the eligibility and also the application process. It's just all summarized in these slides here. And that's the end of my presentation. I hope it all makes sense. Thank you so much for listening. And if you would like to reach me, you can email me at bonnie.nursepractitioner@gmail.com, and I can also be found at the Saint Clinic and also AMA House. And for any referral, feel free to give us a call or send me an email. Thank you very much.
Thanks so much, Bonnie. That was so informative. Does anyone have any questions? Sorry, people have questions, and I will start off by one question says, you mentioned that you test the urine. Sorry, I'll just be 1 second because lots of questions are coming in and I've just lost my place in this first one. You often test the urine with a culture. Do you use dipstick tests?
Okay, so sorry, do I stop sharing now, or it doesn't really matter?
Yeah, you can stop sharing now. That's
okay. Yeah. Okay, good. Yeah, so for my assessment, I like to send the urine off for MCNS. I like them to collect a midstream urine to send for MCNS rather than using a dipsticks. I know people probably have different opinions about this, but I do see a lot of false positive results on the urine analysis, or a lot of the time, rather than false positive, that's probably not the right word, not the best word to describe it, is sometimes patient can have sterile pyuria, which on the urine analysis will lit up in the leukocyte, but that does not necessarily mean that there is a urinary tract infection there, and which affects my treatment. And in fact, if there is a urinary tract infection, I would also like to treat it. I would like to know which oral agent to treat it with. So therefore, sending a MSU for MCNS is more efficient in my eyes.
Excellent.
But it's circumstantial.
Okay. So would you only send CSU or MSU if the person was symptomatic of a UTI?
Correct.
Yeah, okay.
Yeah, but quite often when we do the assessment for a person that comes in with urinary incontinence, they already suffering from some of the overlaying symptoms like urinary urgency, frequency, and urine leakage. So yeah, generally speaking, when I do my continence assessment with those patients, I always will send off the MSU.
Thank you.
Yeah.
The next question is with CAPS, one of the other conditions. So you've got your neurological conditions, then your other conditions. This person, Helen, is asking, am I correct that detrusor instability or detrusor overactivity can only be used if confirmed by urodynamics?
That's a very good question. I don't know whether or not there's an exact guideline requested that it has to be backed up by an urodynamic findings, because I know, in fact, that certain GP will be able to help the patients to apply for CAPS as long as they meet those requirements. But those patients may not have done a urodynamic study in the past with the GP to support that. Yeah.
I think Helen's just saying, I think you said that you can only say that someone's definitely got detrusor overactivity if you've done a urodynamics. So what would you call the condition if they haven't had urodynamics done? What would you say to them? Mrs. Smith, you have what?
Yeah, I will need to have a look at that list again.
Oh, that's okay. No, sorry. I'm just saying, and you said that you can only officially say that someone has detrusor overactivity if they've had urodynamics. Is that correct?
Yes,
I thought on your slide
so,
you said.
Yeah, so if there is, if the person have done a urodynamic study and it is proven that there is detrusor overactivity, then yes. And another thing that I found with the CAPS eligibility, the criterias, some of the terms is actually interchangeable. That's how I feel. Some of them depending on how the clinicians or the practitioners assessments, and with the more, of course, depending on what kind of evidence that you had to back your decisions, because at the end of the day, if you're the one that's signing off that form, then you're responsible to answer those questions correctly to the best of your knowledge. So with us, the luxury is quite often we do have a lot of investigations on the patient's file that when we get to the stage when we help them with the CAPS application, but it is quite a case base.
Yeah, and I personally, if I don't have urodynamics results, I use one of their terms which I don't like, but it's one of their terms, which is called bladder innervation urgency.
Yeah, I think that I can't really remember whether that's on the neurological condition.
Yeah, it's one of them. Yeah, so I don't like the term, but it is accepted by the CAPS team. Okay, the next question is, in what situation would you use TTNS or over PTNS?
So in what situation would I use TTNS over PTNS?
Yeah.
Okay. So with PTNS, one of the things that we need to consider is definitely the scheduling. So for the PTNS treatment, the person is required to come into a clinic or in hospital setting on a weekly basis for the first 12 weeks, once every week for the treatment. Each treatment is about half an hour, and that's the initial induction treatment. And then if the PTNS is improving the symptoms, they would like to continue, then we will move on to tapering treatments, which is every 2 weeks, 3 weeks, and 4 weeks for the duration of another 12 weeks, and then move on to monthly. So this is an ongoing treatment. And again, scheduling is one of the concerns. Second is financial. If the person is having the therapy done in a private, then quite often there's a private fees associated with it. So on such a hectic or intense, for lack of better words, schedule treatments, then that's something the patient will need to take in consideration. TTNS wise, it is something that we can teach the patients to do at home by themselves on a minimum of weekly basis, or some patients will do it a little bit more regularly, and they can learn how to put the patches on their leg, and they can learn how to set the machine up. And again, they stimulate the nerve for half an hour on each sessions, and they usually we encourage them to monitor their progress and come back for follow up in every couple months, just to see how the therapy is working for them. So it's more financially friendly, and also the patient has definitely more autonomy with that therapy. And when we talk about efficacy-wise, they both Pretty similar, but I would say from my clinical experience, the PTNS do have a slightly higher success rate or patient satisfaction rate. But I think that probably has something to do with the needle, being inserted really close to the tibial nerve rather than just on the skin level with the TTNS.
Thanks so much, Bonnie. We'll need to leave it there in terms of questions tonight. And thank you very much, Bonnie. I know you've got a very busy schedule, and thanks for taking time to be involved tonight.
Thank you so much. Thanks, Melissa.
Okay, bye.
Thank you. See ya.
Okay, bye. Okay, now I definitely want to take the opportunity to thank the Education Subcommittee for arranging our two speakers tonight. They always do an amazing job, and they're very, very organised, and we thank them very much. Our next speaker tonight is Janine Armocida. I'm so sorry, Janine, if I've said your surname wrong. Janine is the National Continence Helpline Manager at Continence Health Australia. She and the helpline help nearly 15,000 callers consisting of consumers, carers and health professionals regarding incontinence with information, advice and support each year. Janine has an extensive experience as a Nurse Continence Specialist and has a special interest in women's and children's continence, as Janine is also a midwife and a maternal and childhood nurse. Welcome tonight, Janine, and we look forward to your presentation.
Thank you. Okay, can you see?
That's perfect.
You can see that? Great. Okay. So thank you for that, Melissa. I'm just going to see whether I can move this one because okay. So during this presentation, I just want to quantify the reach of the National Continence Helpline during the period of 2021 and 2025 and demonstrate how our Nurse Continence Specialist-led model delivers free continence advice across the lifespan. And it bridges the specialist waitlist gaps and partners with consumers, carers and health professionals to improve continence outcomes nationwide. I'd also like to thank two of my colleagues at Continence Health Australia, Brenda Ratzingham, who's the Salesforce and Business Systems Lead, and Susie Rathskins, who's the General Manager of Operations, for their assistance with the presentation. The helpline operates weekdays, 8 a.m. to 8 p.m. Australian Eastern Standard Time, and we have 3 nurse continence specialists and 1 consumer representative each day who manages the non-clinical calls. The service also has access to free interpreters, and health professionals can refer or request callbacks for patients to receive immediate education, risk mitigation and referral to services that are in our service directory, helping them to navigate their medical condition during wait times. And the National Continence Helpline is actually part of the National Continence Program, which is funded by the Australian Federal Government. This is a retrospective analysis of the National Continence Helpline datasets from Salesforce. And these were analysed to quantify call volumes, caller mix, caller location and reasons for calling and satisfaction scores. We have a volume of calls about 17,000 per year, and it ranges from 14.5 in 2025 to over 19 in 2022. I guess the discrepancy of those numbers is mainly due that now we're collecting much cleaner data than we did early on back in 2022. 26% of callers ring more than once per year, with Mondays consistently being the busiest days of the week. And 44% of callers were consumers, 30% carers, 17% health professionals, and 9% unknown. Now, just the geographical location of callers and some of the data has also been mapped. 73% of callers were women with an average age of 68 years. In 2024, most callers originated from New South Wales, being 28%, Victoria 25%, and Queensland 19%. When we actually mapped this with the ABS data for the same year, there were a greater number of calls in South Australia mapped to the population, which actually surprised most of us. And this may be due to there's no state-based funding scheme at all in South Australia. There's certainly more work to be done to address the needs of people around Australia by tapping into our state and territory advisory committees to gain further local knowledge and help health professionals understand how the National Continence Helpline can help them and their clients for a better outcome. So the mean duration of calls over the past 12 months was about 12 minutes for calls managed by the Nurse Continence Specialists. Some calls do go for up to an hour in duration. In 2025, symptom advice and self-management was the most common reason for calling. And some of the examples, some of the clinical or symptom advice, someone ringing a husband with Parkinson's, now getting up 5 times a night with worsening incontinence, a child with autism, non-verbal, still in nappies at age 7, or post-prostatectomy, client now constantly leaking despite doing exercises. Then, of course, financial assistance. It might be an NDIS plan, doesn't include continence and I can't afford to buy products, or I've applied for CAPS and I haven't heard back after 6 months. And then product advice, it might be that the product's always leaking or they can't purchase the catheter that they usually use and want an alternative. One of the alarming things that we do sometimes get, and it seems to be happening more often, and this is one, my husband had a catheter inserted 8 weeks ago in casualty, and we're still waiting for the community nurse to get in contact with us. The catheter bag is getting a little discoloured. And that's a really scary thought that they haven't changed the catheter bag at all for 8 weeks. But it does happen, unfortunately, in the community. People are being discharged without adequate advice and support. So despite most callers ringing in distress with a problem, quick polls and surveys capturing experience in 2025 show that 92% of callers rated their call experience as excellent, and 85% of callers felt their questions were completely understood. And 95% reported receiving specific advice that addressed their concerns. And over 93% of callers would recommend the service to others. And that's despite callers generally not talking about their incontinence issues with others. This evaluation data shows that the National Continence Helpline is heavily utilised and caller experience is extremely positive. Now, I just want to finish with a couple of important case studies which I think demonstrate the role, or the important role, I should say, of the Nurse Continence Specialist play on the helpline and also in the community. And to never underestimate the amazing work you all do and the impact a nurse continence specialist can have. We had a caller who emailed us with his gratitude. He was experiencing extreme pain on urination for the last 2.5 years as he had an artificial sphincter inserted. He was getting depressed and desperate, having had an MRI, cystoscopy, several visits to his urologist, GP, and casualty to try to establish why he was in pain, to no avail. In desperation, he called the National Continence Helpline and spoke to a nurse continence specialist. The nurse thought about what she was told and suggested he speak to his doctor about prescribing tamoxifen, thinking it could help with the flow of urine by relaxing the smooth muscle. In his email, the gentleman stated, "I have gone from extreme pain where I feared going to the toilet to having mild discomfort at worst or no pain at all. I know it is the tamoxifen because after the first script was completed, I did not take any for a couple of days and the pain came surging back. It was so severe that I thought I had a urinary tract infection, so I went to emergency. They did a physical examination and urine test, though there were no signs of infection. The doctor suggested I go back on the drug, and it worked almost instantaneously. This gentleman was so grateful to have talked to that nurse continence specialist when he rang and wanted to pass on his heartfelt thank you and a big hug. I think this case study demonstrates the importance of a nurse continence specialist and the high level of clinical reasoning and experience required by a nurse continence specialist to improve the outcome for their clients, or in this case, to a caller to the National Continence Helpline. Another caller contacted the helpline regarding her father after contacting us several years earlier. She took this opportunity to express her gratitude for the support she received years earlier regarding her teenage son, who was neurodiverse and was experiencing persistent bedwetting. The issue had severely affected his mental health and contributed to a suicide attempt. Despite support from a psychologist, multiple GP visits, no effective strategies were identified. Through the helpline, she was referred to a nurse continence specialist in the community who recommended a sleep study. This sleep study identified sleep apnea as the underlying cause. Once treated, the bedwetting ceased completely. Her son is now employed, has significantly improved mental health, and is more confident and socially engaged. Whoever says no one dies of incontinence is wrong. It can be life-threatening, as in this case. Never underestimate the impact and reach a nurse continence specialist can have in improving someone's life. In conclusion, the National Continence Helpline is a low-cost, high-impact service that delivers measurable value and supports a sustainable, accessible, person-centred continence health care for everyone in Australia. If anyone is based in Melbourne and interested in a casual position on the National Continence Helpline, please don't hesitate to contact me. Thank you.
Thank you, Janine. That's fantastic. And just so you know, Janine, there's you haven't spelled continence correctly in your email address.
Oh, no, you're dead right. I will fix that up in the second one. That's because I'm going on holiday soon.
Just so you get lots of applications for your job.
Yes, that would be lovely. Thank you.
Okay, that's fantastic. Thank you so much to both our speakers tonight, to Janine and to Bonnie, and a huge thank you to the Education Subcommittee, because they really work incredibly hard and find us some amazing speakers. Okay, Liz, we might go on to our next slide, please. Okay, so I'd like to advertise the CONSA conference, which is on Friday the 16th and 17th, Saturday the 17th of October this year in Brisbane. We've got, on the first day, we've got workshops. The first one's on pessaries, and the second one is on back to basics, continence assessment and management. The workshops are filling up really, really fast. So please, if you'd like to attend one of those workshops, or just in general, if you'd like to attend the conference, please go on to the CONSA website and you'll see that there's an option to register for the conference. The second day of the conference will have a scientific program. The conference is at the Pullman Brisbane Airport, so there's multiple people who are flying in on the Friday morning for the workshop, which starts in the afternoon. So that's why we chose the airport to hopefully make it easy for people all around Australia to get to the conference. And I want to also remind people that there is a Rising Star Award that CONSA is offering, and the Rising Star Award is for, you can apply for it yourself or you can encourage someone you know to apply for it. The main criteria is someone that, either yourself or someone else who you feel that is a real star in the field of continence, and we want to really encourage people to get into the field of continence. And you will have your conference registration paid for, and what else do I need to tell you about that? the Rising Star Award applications close on the 31st of August, so you've just got a few more weeks to apply. And we've had some fantastic applications, but we are keen to get more applications because, as I said, we really want to encourage a new generation of continence nurses. The main criteria that's of relevance is that you have to have been a member of a CONSA for less than 10 years. Okay, there's one chat that I just want to have a quick look at to see. Basically, we've just got some lovely comments about our speakers and thanking the speakers for their presentations tonight. Okay, as there's no other things mentioned in the chats, I'll just check with Liz if there's anything else that we need to speak